everyone, and especially if you're on the East Coast or somewhere far in the future. So we're going to do some quick intro stuff, and then we'll get to the heart of this, which is talking about how you can succeed on your rotations. So we'll do some quick intros, and as a little bit of flavor here, we're each going to share our craziest rotation story, but we'll make it quick. So I'm the creative director here at Sketchy. I graduated from med school in 2018. Feels like a long time ago now. I did a year of, did my intern year as a urology resident at UCLA, but then realized that my destiny was to make cartoons for all of you. So I left and came here to Sketchy. My craziest rotation story was an ED thoracotomy, which I know Connor's all excited now. I was on a trauma surgery rotation. We had a trauma come in. He coded a couple of times in the trauma bay. And so I think the attending was honestly a little bit of a cowboy, but he was like, all right, we're cracking his chest. So just right there, like in the CT scanner, we just opened him up. It was one of those, it was like out of a movie. Like the chief resident was beating his heart with his hand, and there was blood everywhere. And there was like a little laceration that the chief had to sew up, and he was trying to sew it, but his hand was shaking so badly that I had to take an instrument and grab the needle from him every time he passed it through the wound, and then pass it back to him because he just like couldn't. It was a mess. Anyway, that was a real pulse pounding kind of wild moment. Definitely something I've thought about a lot since then. And we'll end the story there because that's a good place to stop that.
And I'm Connor. I'm one of the Sketchy ambassadors. I've been fortunate to work with Sketchy for a few years now. I'm a brand new fourth year at UCI on the West Coast in Southern California. That story is very applicable to me because I'm applying into emergency medicine. That kind of story sounds like something I don't want to do every day, but if it needed to happen, it sounds like something that I would like to do. And my kind of craziest rotation story, very similar actually. It was a early morning, and here at UCI, Thursday mornings, the emergency medicine residents do didactics, so it's just a couple attendings, and that's pretty much it. All our teams were really busy. We had multiple cases going on, and there's a trauma who comes in that's sick, but not that sick. And by the time you finish third year, you'll have a better understanding of what that difference is. And the really cool thing was it was just a fellow and the EM attending. And typically the EM attending is just kind of, charting away, and the fellow is also charting, which meant that I got to very politely ask if I could run the trauma. Again, I guarantee you, patient was not that sick, and there were doctors watching me, but it was really fun to be able to do a trauma all the way through, because I know some hospitals will share with EM and trauma and whatnot, but it was a good experience to have as a third year, and something that I can look forward to doing for a good chunk of my life. That's me.
What's up, everyone? My name's Nick. I'm a fourth year at Larner College of Medicine in Vermont. I'm applying into anesthesia. My craziest rotation story was last year on IM. I think I was just rounding in the morning, looking at my patient, and I randomly, I was looking, he was there for some kind of respiratory thing. I looked at his chest x-ray, and I was like, oh, I think that's a pneumothorax. It was like a unilateral pneumothorax, and I was like, that's pretty wild. He's still on the floor though. And I kind of sauntered into his room. I was like, I'll go check and see what's going on. And then as soon as I got into the room, I was like, oh, this guy's very clearly in respiratory distress, not having a good time. And then the critical care fellows are kicking down the door 2 seconds after I get there. And then I'm holding this guy down, and we're putting in a chest tube with very little anesthetic, very, very quickly. Again, it was just one of those situations where you're like, wow, it just happened really fast, kind of like a movie kind of thing. It was cool. And he did all right, so happy ending too. But yeah, that's me.
Was putting in a chest tube with no anesthetic the moment you decided to go into anesthesia?
No, I'm still pretty interested in critical care though, so that it was cool. He was running me through the steps as he did it, which was pretty wild that he was confident enough that he could run me through it while doing it. But Yeah, it would have been nicer probably if he had a little bit more local anesthetic in there.
Yeah, for sure. Always is. Um, Amazing. So yeah, thanks to you both for being here. We're going to quickly talk about a big upcoming Sketchy release, and then we'll talk about how to prep for rotations. Nick and Connor will kind of take you through what they're like, how to prep, how to do well, and so their recent and hard-earned wisdom. So first, I want to talk quickly about our new and exciting product. This is something that we've been working on for quite a long time here. Actually, I think, Connor, we showed this to you like way back at the end of last year. So you got a very, very early sneak preview of this. But we've been working super hard on it. We're super excited about it. We've felt for a long time like there isn't a great resource for clinical students while they're on the wards. And so we tried to make it. So this is kind of a new version of Sketchy that includes videos, because Sketchy videos are just like something truly special, but also tries to incorporate that content in a new way that makes it easier for you to use while you're a super busy third year, while you're on the wards, and helps you get more of that sort of clinical approach to medicine. So we've got videos, we've got text and image cards, we've got anatomy, like you can see here. There's tons of quiz questions. We have something called cram cards, which are kind of like you're about to walk into a patient room and you want to know sort of what the attending is going to expect you to ask about and look for, or you're about to take your shelf, or step two, like what are the things that you're sort of going to be kicking yourself if you miss about a particular condition on the test. So we put all that together in a package that kind of takes you through each relevant condition, and we sort of group and tie conditions together in a way that we think is pretty intuitive. We take you through presentation and diagnosis and treatment, sort of again like the clinical approach through a patient story. And the goal here again is twofold. We want you to do well on your tests, because like that number is really important. But we also want you to actually be good doctors, and so we really think that this helps you think about clinical reasoning in kind of a new way. Our family medicine lessons in particular, I think, take a really unique approach to teaching clinical decision making. So we're really excited about this. For now, this is coming out on June 20th. That's in 2 weeks. Our engineers are like, we've locked them in a dungeon and they're not allowed to leave until June 20th. No, that's not true. We're very nice people. But it is coming out very soon. And then later in the summer, so that's on the web for your computer and for your phone. And I know like web apps are whatever, but genuinely this is much better designed for your phone. And then later in the summer, we'll have a real honest to God iOS app that you can download and install and use like a normal person. So what is all of that? It's about 250 new or revised clinical lessons, and revised here means that we've really added a bunch of content to them. As always, it's still the same deal where you get preclinical along with the clinical stuff. So the Sketchy subscription always comes with micro, farm, path, etc. But now we've got this sort of souped up lineup of clinical courses, a brand new psych course. We've never had psych before. Same for family medicine. That's all new. We've had a little bit of neuro in the past, but we've sort of rounded that out and made it into a complete neuro course. And then pediatrics, same deal. We've really fleshed that out and made it a full course. IM and surgery and OB-GYN are sort of the same for now, but there's updated content coming for those later in the summer. And then we're also trying something new. And if you're watching this and you try out the new app, we'd be very curious to get your feedback on this. So we have these longer sort of scenario-based assessments. They're not everywhere yet. They're just sort of in our 3 sort of OG courses. But they're like unit tests or sort of more meant to mimic, not necessarily a full board style section, but sort of along those lines. They're meant to be a little bit longer, a little more in depth, and kind of ask you questions across a whole unit. So if you have a chance to check those out, we'd be really curious to hear your thoughts, because that will help us determine if y'all want more of them. So again, June 20th, new stuff coming out. Very exciting, many colors. It's going to be great. Here's a QR code. If you sign up for our wait list, we'll let you know exactly the very moment this launches. I think it's going to be at something like 4 a.m. on June 20th, 4 a.m. Pacific time. So don't worry, we're not going to like ping you right then, but you'll be the first to know when it launches. We'll sort of wrap up with this a little bit too. But for now, let's hand it over to Nick and Connor to tell you how to do well on rotations, what to expect.
All right, guys, I'm going to take the first couple slides. So a lot of what I'm going to talk about, I help, I'm in the process of helping write the IM and the surgery guides that are not out yet, but a lot of this I'm kind of drawn from there. So, yeah, I'll just kind of go through this bullet point by bullet point. But yeah, it'll especially like the bigger rotations, IM, surgery, OBGYN. I know the people who are on it, you're getting there pretty early. Surgery, probably the most early. OBGYN is a close second, though, because generally you're going to be pre-rounding on patients before there's rounds, so you can present people. So there's like your pre-rounds, there's rounds with the residents, and there's like rounds with the attending. So definitely early morning. So definitely make sure you're getting to sleep at a good time because you want to catch stay up on your sleep because these are long, grueling rotations, or they can be. Some are a little bit more chill, but yeah. So it's going to be hard. Going to be a lot of early mornings. You're going to be interacting a lot with residents. So obviously, like we all know, you're going to get pimped by attendings. Like that's a big thing. But residents. Like you are with the residents when you're pretty much the whole time because they're pretty much there when you're where the attending, unless they're at didactics. And a lot of times you're going to their didactics as well, unless they don't want you there. And then maybe with the attending. So get to know your residents. You want your residents to like you. I always like to say, like, don't be a suck up. That is annoying. And, they can tell if you're like being like a gunner or like not treating your other students like with respect and stuff like that. But again, like they're going to write your evals. So it is helpful if, they don't hate you too. They will, you don't have to be their best friend, but be someone that they don't, mind having around them because you will be around them all the time. And I think it's somewhat of a harsh truth. Like we're medical students. This is bring your son to your daughter to work day at some level, right? We're there to learn, but we are also in the way and we don't know that much yet, but you will. Okay. So like, again, just be aware, right? They're doing stuff. They're working hard. We want to learn stuff, but residents really want to have a good relationship with them. Yeah, I like this one, pretending to be a doctor. My mom has a great saying. She always says that she's like a pretty important lady at this point, but she's always like fake it till you make it. Um, I think like every school, my school talks about this all the time, where it's like the imposter syndrome thing. It never goes away. I don't think it goes away even for new attendings. Maybe it goes away for attendings who've been doing it for years, but new attendings, they have a whole different set of imposter syndrome. Like the interns that are about to start this month, yeah, they have a huge set of imposter syndrome. We have our own, right? So yeah, it's what it feels like for third year, at least for me. You're really like, you might know of some things you're learning, but like you're kind of pretending to be a doctor. But here's the thing, the patients don't really know this. They don't understand the whole process. So have some confidence. You're there for a reason. But again, we're kind of playing a role and we're getting more comfortable, but just have that confidence. Everyone feels the same way. I don't care how much of a stud that medical student who's on your rotation who comes in and they're like all fancy and shiny and they know everything. Guess what? They're feeling the same thing. They're just covering it up well, what we're really doing third year, fourth year, you're acting like you're doing your sub-Is, you're acting a little bit more like an intern. History and physical exam. This is like such a big thing. And this is what you're doing. And like, I think we all like, we kind of know, like, it's like different for different rotations, right? Like you're learning the psych exam for psych. You're learning like that really comprehensive physical and like HMP, just the HMP for IM. Surgery, it's different. So you're getting thrown into all these different rotations pretty fast. But what you're taking from each rotation is really, you're just trying to do a couple things. That's what you should come out with is, and usually what that ends up being is like the HMP for that specialty. You want to try to get good at that over your rotation, right? You have some time. You're not going to be good necessarily, or maybe you will be good. I don't know, but there will be room to improve. And that's kind of what you're getting graded on, right? Like it's not the start, it's like the finish when people are doing your the resident reviews, the attending reviews, whatever those Likert things, your MSP comments. So just focus and improve. But H&P, that's like the big thing for medical students, right? We're not doing all the procedures in the world. I mean, I love procedures. I do every procedure that anyone will let me do. But we're doing H&Ps. That's what we're doing. That's the main thing you should really take away for being good at during third year. Yeah, you're gonna get pimped. I think it really depends. At my school, people are pretty nice about it. I think they tell the attendings to be nice to you about it. I don't know if it's like that at every school. I'm sure medical culture differs. I did my third year not in Vermont. I did it in Connecticut at a couple of more community hospitals. Again, people were still like you get some people sometimes who will not be the nicest if you don't get your question right. But here's the thing: they're going to ask you questions because eventually, when you are actually doing things and making decisions, like it's helpful to be able to like someone asks you a question like what are we going to do for you to be able to come up with that answer, right? So it's all just right. Like don't hang your hat on getting something wrong, but it's just reps, right? We're just getting used to this. This is like to try to like put you in that feel like you're in that clinical situation where you now need to make a decision, right? You're in charge. You're the resident. You're the attending. People are looking to you to actually make a decision. You're a med student right now. So this is just practice, right? So again, if everyone has bad days. Some days I get nothing right. I get no procedures right. You have better days some days, but just constant improvement. If you don't get something right, figure it out. Why didn't you get it right? And come back. So what I like to do when I get things wrong is I will go find that attending or that resident and I'll bring it up again and I'll be like, hey, I know why I was wrong about that before. I looked it up. I think people like that, right? Because it shows like you're actively trying to learn. You're trying to like learn from any mistakes you might have made. Again, I think what I've just talked about is just like really into this next point. I think now in med school, people are like different ages, right? So we're all growing personally wherever we are on like our journey of life. I'm a little bit older. I'm 31 at this point. I have classmates who are like fresh 21-year-olds in my same year. So we're all in like a different stage of that journey, but we're all growing personally as people because our lives don't stop once we're in medical school. They really very much continue. And we're also growing professionally, right? So we want to grow up, not down, or forwards, not backwards, right? So again, we're not professionals yet, but we can act like professionals and we can learn from the mistakes that we're invariably going to make, right? So again, just really focus on like think about who you were at the beginning of third year. I guarantee you it will be different by the time you're done with third year, right? So cut yourself some slack. You'll make mistakes, but you'll be a very different person. You will definitely improve at things. A lot of memorable moments. I feel like we all just shared a few. There's going to be a lot of them. Third year is awesome. I loved third year, man. It was so much fun. You have to study at the same time, which Connor will explain. So that never goes away though. So attendings and residents, they're taking exams all the time. So this is your life. You want to be a doctor? Guess what? You're taking exams for the rest of your life ultimately. But third year is like, dude, you're doing medicine now. So much better than just studying for step one. Step two is I haven't taken it yet. Taking it soon. It's better too. It's all clinical. You're going to use it all the time. All right. I think we can go over to the next one.
I just want to say, I want to say one thing because those are all amazing points. I think your point about residents is like, it could not be more correct. And I think having seen that interaction from the other side, it's always very obvious what the med student is trying to. It's funny, like when you're a kid and you think you're being sneaky, and like now I have kids and they're not sneaky at all. It's the same thing, right? Like you're a med student, you're like, I'm going to try and outwit the system. Like residents were there and they know it and they can watch you do it. So I think that you're always transparent. So just be transparently helpful and enthusiastic. Like it's the best.
Yeah. If I can build off that, Ben, sorry, that really reminds me. I had one OBGYN resident, and she had this great thing where she was, and I'll relate this back to an earlier point I made. She was basically like, we don't really expect med students to know anything. If you can be helpful, that's awesome. That's just like money, right? That's just awesome for them because like I said before, like it's kind of like bring your kid to work day and you're there. So what's helped me with residents, I think, is just like I just try to be helpful, even if it's like I'm picking up their trash. I was in the OR today, and uh, it was it was not an awake craniotomy. She was put to sleep, but head was away, so I didn't get to intubate like I wanted to, which is fine. But I was like right there next to her. I grabbed all this resident's trash. And she was like happy by the end of it, right? So even if you're just getting the trash, even if you're like taking the bed out during surgery, even if there's stuff that you're doing that you don't maybe want to do, and you're like, that's not really why I'm here. Guess what? It goes such a long way. If you can just be helpful, because again, then guess what? Those residents trust you more. They're going to give you more stuff to do. All right. And like Ben said, if you're not trying to game the system and get and like not put it that work in, like they will find out. I had a resident tell me once, she's like, yeah, like all these med students are great, but like, I see them in the morning and then they just disappear and I never see them again. And I know what those kids are doing. They were studying, which is great. We all got to study, but they noticed and they're writing your reviews. And they were med students before. So yeah, guys, we can't trick this.
And just remember, their life is a million times worse than yours. And cut them some slack. Okay, enough of a pitch for residents. All right, let's move on to the next one.
All right, yeah. Okay, cool. And Connor, again, if you want to chime in at any point, because I am wrong most of the time, please do and assist me. All right, yeah. Getting there early and on time is huge. And I'll be honest, this is not my strong point. I'm not. I was the kid who I was figuring out how to see my 3 patients on IM with like 15 minutes before I get there. Don't be me. Be there on time. It's just so much better. Things go so much smoother when you have more time to pre-round. So getting there early, um, making sure like, I mean, usually like they give you access to like, I can get Epic on my phone or you can get like a virtual desktop. You could even look up your patients like the night before if you have time. You're getting there, get there early and on time so you can pre-round and you know your patients, right? On surgery, you know your patients, you know why they're there, you know what the surgery is for. I am, all that jazz. And you'll figure this out once you're on rotation, but being early enough or on time. Probably let's be early. Let's not even say be on time, right? Let's try to be early. I think it just makes the rest of the day go so much smoother because maybe then you have a couple minutes to chill. You can get coffee. I'm a huge caffeine person, so if I'm running late and I don't get my caffeine, then I'm dealing with a huge headache for the rest of the day. And guess what? That's not super fun. So, all right. We already kind of talked about this, but yeah, extra patient tasks, things that are a little bit more menial that are helping your resident, huge. And I won't go through it again because I already got on my soapbox before, but it just being involved. And it's like, I know it's such a dance and like Connor will talk about studying, but like this, for me, this was like, it was just like they were like, yeah, get through all of UWorld, and then you want to get through all of UWorld, take all these MBMEs, and it was like, dude, I want to like be involved in this rotation. Like, I want to help people like admit patients and like be there till 5. So it is like it will definitely be like hard, but it's nice to be involved and like really be in there in the trenches with your residents and helping them because they're like Ben said, they're so busy. It is so much worse than what we're doing. Okay. We don't really have any real responsibilities. Ultimately, I know you do, but you don't, right? The hospital's not running on whether or not your note gets done. We talked about it as well. Yeah, just that if you just get the H&P and the physical exam down, that's like the main thing. I would say too, like if you're writing notes on that rotation, again, if you've never written notes before, they're not going to be perfect. It's all just like improvement. But I would say always asking for feedback, super helpful. That's really how you improve. And usually people are like very happy to give you feedback. In fact, if they're a resident and they're an attending and you're at an academic institution, they actually have to give you feedback, I'm pretty sure. So yeah, ask for feedback. It just helps. They've been doing this a little bit longer than you. So never be too proud to ask for feedback or for help. Yeah, being kind. Oh man, this is huge. Don't be an asshole. Sorry, I probably shouldn't swear on a webinar, but really, just don't. There's no point. And I don't care if it's a nursing assistant. I don't care if it's patient support. They're like bringing someone, like treat everyone like you would want to be treated yourself. Treat them like they're also a doctor, because I know there are people out here who also probably worked like doctor jobs before they got here, right? I was a nurse assistant before, I was an MA before, I've been a lot of other entry level jobs making minimum wage, and I always really liked the doctors who were nice to me. So this will just help because then you won't slip up and be mean to the person who's writing your the residents and the attendings who are like doing your evals, right? But these people, like, if you have an issue with a nurse, like, I get it, like sometimes these people are busy, they have their whole jobs going on and stuff, so maybe they're not the nicest to you that morning, but they're not, it's not just residents and attending that are also giving in feedback. Those attendings and the nurses are pretty tight and they will talk, so are the residents. So just be kind. Just be like a nice human. I'm sorry if you hear them barking. My dogs are about to, they're fighting over a ball, so I apologize for that. Yeah, this last point. Yeah, so again, like I kind of said before, like the patients don't understand how. I mean, maybe they do. Maybe they have some medical family, or they're a doctor themselves. Those are the worst, not the worst, but those are the most intimidating patients to get when they're actually with their doctors or their medical professionals. But they are still going to look at you with some degree of like feeling like you have authority and you kind of know what you're doing. So I think this was really put well to me on surgery. It's like it is a privilege to be able to get in the room in the OR or to help take care of these patients, right? Because these patients are, whether they have insurance or not, like somehow they're paying to be here. They're in a very vulnerable position, and this is kind of like hopefully what your school has been talking to you all along, is that like this is where professionalism comes in, right? They are going to look at you for help in this situation. You're part of the care team, so you really got to act like that, even if it feels like you don't really know what's going on. Believe me, that's me. That is residents every single day. But patients don't know that, right? And you have a lot of power, even just as a medical student being on that care team. So please treat that with the respect that it deserves. And just, yeah, they are going to look at you maybe not as their doctor, but there are times you will walk in and the patient will think you're a doctor. You want to be called a doctor? Just walk into a patient's room is like altered mental status. They're hyponatremic. They don't know. They think you're a doctor. So, you know, it's hard because we don't necessarily feel like we are, but we are. All right. And maybe to them. So there you go. Sorry, I'll get off my soapbox now.
I mean, I think that's a really good point, and I actually think it goes really well with your previous point, which is you may not always know all the answers. You don't necessarily know their full care plan or their whole story or whatever, but you can always be kind to them, and that is so valuable to patients. Their residents and their attendings like are super busy during the day. They're not going to spend a ton of time with them. They don't have the time, but you often do. And so even if you can't give them every answer, you can sit there with them and listen to them and chat with them and say you're going to go find the answers.
Absolutely. Yeah, it never is a wrong answer to be like, hey, I don't know, but I can go find out.
And then I'm glad you started with arrive early, because especially on your first day, like please show up a little bit early. We had a student when I was an intern who prior to this guy, everybody had kind of showed up at the normal like 5:45, 6 a.m. like rounding time, like ready to go. They didn't have any patients yet or anything, so there was no expectation they come in super early, but like they were there when we were there ready to go. This guy rolls in around 9 a.m. on the first day. We've already like seen all the patients. Like someone had been to a case in the OR and was done already. He's like, okay, cool. So what are we doing today? Like that was his reputation for the entire rest of the rotation. Don't be that guy. All right, cool. Connor, are you up?
Yeah, and I would have interrupted you, Nick. I agree with everything that you said. Honestly, of that entire discussion, just be a good person. Like it was kind of the same way that I give interview advice to people applying for medical school. Really, that interview is kind of just make sure you're like not a sociopath, psychopath, yeah, anything like that. Like just be, be yourself, be kind. And that's my biggest rule of like, and just something that I have learned the hard way. It, MSRE is hard. And everyone working in the hospital who has a job, that is hard too. They may be having a harder day than you. And sometimes if they get upset with you or say something, that's not necessarily a reflection of you. It could be just a reflection of the day that they're having. And that's just something to always keep in mind. Now, unless you're chronically a mean person and cussing at them and blah, 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 different discussion, but we're going to assume that's not the case. So we're going to get a little bit more into the meat of kind of how to study. And of course, I want to leave time for questions at
Really
the
quick,
end.
Connor, because
Yeah.
this is kind of an interesting, like very specific question, but something that I feel like is actually a source of some anxiety. Catherine asked, how do we introduce ourselves? Like, what do you, when you walk in a patient room, it's just you.
Yeah.
What do you say?
Yeah. So when I am walking in, I say, hey, and now what I say on an OSCE is a little bit different than what I say in real life when I'm not being graded. But in real life, when I say is, hi, good morning, my name's Connor. I'm the medical student working on your team. And that's pretty much it. If there's anything more, then I'll say, hey, I'm the medical student on your internal medicine team helping take care of you today. My resident physician, Dr. Hutt is going to be by a little bit later to see you. And if I don't say that in the beginning when I introduce myself, I almost always say that at the end of talking to them because I want them to know, one, someone is fact checking me. The resident legally has to see the patient. And two, just so they know, hey, I know it's 7:45. I'm sorry I woke you up, but someone's going to come in a little bit. And then I always say my attending is going to come in later too with the whole team. So my introduction in the beginning is pretty short. Again, hi, my name's Connor. I'm the medical student on your surgery team. You might see me in the OR, and then I will probably make a joke that they're probably already asleep, so they probably won't remember me. So I try, depending on the time of the morning, try to joke with them too, and just if they're clearly in pain, then I get right to business, get what I need to do. But I am the chronic person who gets docked on every OSCE that I do for finishing too late past the time because I will not cut off a conversation or be able to connect humanistically with someone just to get full points or just to get out of the room quicker. I'm sure I will learn to do that later, but at this point, I like talking to my patients and I'm happy to lose the points on an OSCE. But yeah, that's pretty much how I introduce myself. I also just want to point out introducing yourself to the team is similar. First day, get there a little bit early, 10 minutes or so. Say, hey, I'm Connor. I'm the third-year medical student on your team. That's pretty much it. They're used to med students. They're used to it. So it's really just the same thing. I just make sure everyone kind of knows who you are. You don't need to introduce yourself to every nurse that you work with or whatnot, but the attending, people in the OR, your actual patient, just introduce yourself. Make sure they know who you are and make sure you say you're a medical student. That is the biggest way to avoid trouble.
I think it can be a little awkward at first to like constantly say, I'm the medical student on the team, or I'm the medical student with attending with Dr. Davis or whatever. But that like extra little bit after the normal part of like a regular human introduction, like situates you in everybody's mind and makes everybody comfortable with where you are. So it's a little bit awkward maybe, but it's important. Sorry to interrupt, Connor. Please continue with your
it's
tips
a good question. I saw it in chat and I was like, I wonder how I should answer that. Because I do think, and how I introduce myself in the OR is, a little bit differently too to like staff. But it very similar. Hey, I'm Connor. I'm the medical student covering this patient. Essentially just my name, the student, what my role is. That's essentially just rinse and repeat what I do. So studying on rotations. This is no one's favorite part of third year. And I guarantee you, just like Nick said, those people who skip out on things to study, it will be written about and they will talk and it's not fun. So I'm not saying you can't study on rotations because guess what? You can, but you should be aware that you're paying to be there. But what you're paying for is the experience to be with patients and to take ownership and to do things that you have never gotten to do before, but you're going to do for the rest of your life. So my tips and tricks, just studying in third year, because it's a lot different than first and second year, and even can apply to fourth year. This just works for anyone who's a clinical student, right? I like to set a game plan of what I want to accomplish in a given rotation on a specific week and on a single day. I know that sounds like a lot, but I am the type of person that will schedule my day out semi by the hour, but more likely just have a to-do list for that day. And I'm going to even show you what my to-do list looks like in a couple slides. But this is what I like to do. You know, before starting internal medicine, there's 3,000 UWorld questions. So I say, you know what? I'd like to do 2,000 of them by X date. And then now it's this specific week where I know Friday is going to be a really long day in the operating room and I'm not going to want to study, or I'm married. Maybe I have something going on that weekend or something where I can't. I need to budget time for that. And you have all been practicing. That's really what med school is budgeting your time. You've been doing all that for 2 years now, at least. So we're going to keep practicing and we're going to keep doing it. Similar point. I think less is more here. Now, I'm very much so different. I think for step one or, level one, I kind of don't agree with less is more. I think there's a lot of resources and I think they're all great. And there's a lot of documents that other med students have made, divine intervention podcasts. There's numerous things that you can use. And I think kind of dipping your hand in each one of them, or dipping your feet in each one of them, it's not a bad idea. But when it comes to clinical life, less is more. So choose your resources wisely. Of course, I'm going to say Sketchy because I'm here, but I would say that wholeheartedly, even if I wasn't here. I use Sketchy in third year for sure. I'm using it studying for step 2 right now, as well as a good refresher. We're not going to comment how I've needed to refresh on the difference between like gram positive, gram negative. We're not going to say that ever happened, but it did. And we're good now. Sketchy saved me. But I like to have something for content, something for questions. That's essentially all I use this year. Something for content, something for questions. And leading on to that, so every rotation, for the most part, you learn the foundations. So you learned that in systolic heart failure, which guess what everyone calls essentially HFrEF, or heart failure with reduced ejection fraction. Welcome to third year, where everything you learned has a separate name. You learned that it's a pumping problem. The heart can't pump that blood out. Well, now you need to, that's great. You have the basics. But when I tell you what is the GDMT that you're going to use, that might mean nothing to you. But by the end of your internal medicine rotation, you're going to know my go-to medications for systolic heart failure or HFrEF, beta blockers, ACE inhibitors, and Entresto. You're going to be able to list all these things and know why. But you'll learn that at the end of the rotation by just kind of absorbing it. But that first time you get asked that question, it's not going to be fun. You're not going to know what's going on. So I like to focus on content earlier in the rotation. Pretty much the first half or first third of a rotation, I really try to learn the content behind it. This applies a lot to things like pediatrics and OB-GYN, which to me, at my school, we kind of talk about the pathology, but not really. Like you kind of know what endometriosis is, but have you ever seen someone with it? Unless they tell you, likely not, and you don't really know. But this is just something that you need to learn. So specifically for peds and OB-GYN, I do more content than anything because those are pretty, I'm going to call them brand new for all intents and purposes, because yeah, you've learned it. Pediatrics hits a lot on, bacteria, fungi, various things like that. But OB-GYN is kind of, a little random. It's a subset of the population and it all has different things, especially now let's throw in pregnant people and it's even more of a different population. So focus on content early to build your foundations, just like you did in first and second year. And then I then incorporate more question-based practice later in the rotation or earlier on, depending on how I'm feeling. And I try to do all of the MBME practice shelf exams before the real deal. So at my school, we take let's just call it surgery, the surgery NBME on the last day of our clerkship. We do it for all of our 7 clerkships. So the MBME provides 3 or 4 practice exams for each one of those. So I try to get them done. I do 1 a week before leading up to the real deal. Now, it's unfortunate, kind of expensive. They're not the best questions, but it's from the test writers. And so that's why I use those. And the last thing I'm going to say here is many of your rotations, minus peds and OB-GYN, are going to overlap. My last rotation was surgery. And I can tell you how many of those surgery questions are actually just an internal medicine question at the end of the day. It's crazy. Or peds questions, when in doubt, you're probably going to operate. Like they need something to happen. So you really kind of will learn that minus those two rotations, you get a random psych question in the middle of your internal medicine shelf. You've done psych. You know it. You can answer it. You don't really need to study it. And that's where we could spend a whole hour talking about the order in which you have your rotations matters or doesn't matter. That's a different point. Next slide, please.
It definitely matters.
Oh, sorry, go ahead, Nick.
It's just, it's a joke. Like I know some people who like they really want like one rotation schedule, and then I was like very much like I'm doing internal medicine before surgery. It's like it's a whole debate.
Med students will debate everything.
I wanted to echo your point about content review for peds and OB-GYN. I had OB-GYN as my first rotation, and I got there and I was like, I thought I just spent 18 months learning all of medicine. It turns out we've completely skipped this topic. So those two are kind of different than probably most of what you learned in your first couple of years. Peds is basically like medicine for an entirely different species. So yeah, highly recommend content.
And just a shameless sketchy plug, the OBGYN content is probably some of the best. The OBGYN course is probably some of the best sketchy clinical stuff out there. I think I did almost all of it when I was on like nights in labor and delivery. Truly, because again, you don't really know that much about it, or you've done very little of the path. The sketchy stuff it's really good. It's nice and short. It's huge part for it. Really helped me.
All right, Mr. gets points off on his Aussies for going too long. We got 15 minutes left.
I know.
A little time for questions.
I know. So this is my example study schedule. This is pre the implementation of full sketchy clinical. As you can see, it's just some like Excel spreadsheet that got passed. Actually, this one I made myself. Some ugly colors just to make my brain work. In the top left, I break everything down by how many questions do I need to do per day. I input everything in, how many donkey cards do I need to do per day. I track my practice exams. And this is literally, do I need to remind myself to do 16 questions a day? No, probably not. I probably, if I did 10 and I did 20, it doesn't really matter. It'll average out, right? But I like this idea of clicking this little checkbox. It brings me the most dopamine in the day when I can click the checkbox that my studying's done for the day. And I don't know about your school, but we have a bunch of random assignments during third year. I like keeping track of those because it's very easy to miss and to forget doing them. So I like having an assignment tracker as well. But this is just what my crude study schedule looks like. Now, the next slide is going to show what it would look like now, June 20th and beyond. So week 1 to 2, I'm going to focus on Sketchy as my content basics. I'm going to be honest with you. I completely agree with Ben. I don't think there's a lot of good, third year content resources. There's some out there, Boards and Beyond, Online Med Ed, First Aid. Those all exist. Those are all things. But they're really passive, in my opinion. And I will fall asleep doing various things like that. So week 1 or 2, when I need to focus on content, we're going to Sketchy. Week 3 to 6, I'm going to focus some more on practice questions because guess what? You got to apply the knowledge. And then week 7 to 8, these new cram cards are my favorite part of the new Sketchy. They are everything you could want in like one small, they're not technically a flashcard, but in one kind of small box. It is a great way to refresh before the exam. So this is what my sheet looked like for MS2, where I had the names of the Sketchy videos written down, how long they were, and when I did it. All I would make that change for third year is to write down the names of the clinical videos. The 59 or whatnot from OB-GYN, I would just put those in here and I would do the same thing. I would track when I did it. I would hit the check mark. I would write the minutes down so I can account for my time. Rinse and repeat. It's this, essentially, I would use Sketchy the same way that I used it during second year and studying for step 1. Just now, I actually have a content base, so I don't go into UWorld getting 5%, which is completely normal if you do it. But now I actually have a chance of getting like a 20%. Next slide. And I think this you, Nick?
Yeah, that's me. So I do things pretty similar to Connor. I basically look. I think there's some slides. I don't know how well you can see them too, but I got like highlighted down there my step 2 on like cool clinical, and this is like what I'm doing for step 2 right now. So it's everything together. But I basically would like just go in and like use the tags for OnKing to know what I need to do. So that there's like, if you go to like, you go to like version 12 of like step 2 OnKing deck, there's a shelf tag. There's a really good tag where it's like cards that OnKing did. He only did like 4,000. He didn't do all of like the 13,000 cards that's in the step 2 deck. But I would just like, I would click on like that shelf. I get all different tags that were for surgery basically. I'd throw them into my clinical pool deck, and then I'd like look at how many cards I had, and if yeah, like whatever, if it's like 3,000-4,000 cards, I think it's less if you just do the OnKing ones that he did. But then yeah, just try to do them per day. And I would do the same thing for UWorld. I would go into UWorld down here, the shelf subjects. I just click on the shelf subject, and I'd be like, oh, I have like I can't remember roughly for OBGYN, you have like 600. I got to do X per day. And if you go to the next slide, I think I just said with one more thing. And I think it was on your thing as well, Connor, just doing UWorld incorrects. I kind of wish that I did this more during shelf, but I'm doing it a lot for step 2 practice now. There's like a plugin. I think you have to go to like Anki Hub and like go to like Anki World. You pay like $5 a month or something for it, but it basically like lets you like take your incorrects off your UWorld tests, where if you go to review, you highlight only incorrects, and then you go to your question list, you can copy those and you can put them in. You go to browse, you hit UWorld on the OnKing thing once you have the plugin. Then you will insert like the comma separated values of the questions, and OnKing and like his team, they've like tagged those questions. So you can basically like add Anki cards that are pertinent, that they've tagged as pertinent to the UWorld question you didn't get correct. So I kind of wish I did this more on shelf. And Connor, it looked like you had a section for that too. So super helpful, because I mean, you're going to get UWorld questions wrong. We all do. I was like a 55% for my first pass.
No, you got UWorld questions wrong? No way.
Yeah, everyone, you do. But if then you can practice the incorrects, and I'll just like do a separate deck of my UWorld incorrects as well. Sorry, I don't want to take too much time.
I know you said the check mark was the dopamine rush, but I think there's no greater feeling in the world than getting something right where like 3% of people got it wrong. 3% of people got it right.
Oh yeah.
What a rush.
I gotta say, I turned that feature off.
Ooh,
I think
hot take.
I think it's very anxiety provoking. Now, when I'm having a good day, yeah, that feels great. Oftentimes, not having a good day, I turn it off. And if I get it wrong, I get it wrong, so what? For anyone who kind of struggles with, comparison is the thief of joy and various things like that, all your popular question banks, you should be able to turn that feature off if you want. So that is my hot take. I hate that feature. I think it's a great feature, but I hate it personally.
That's just called self-care right there. That's great.
Chat loves you for that too.
Yeah.
Oh yeah, this is just, again, I use the Sketchy videos for content as well. So I think I got through most of the surgery videos. And then yeah, I think I've just got on there another picture of when you go to the tags and just looking at the tags for surgery, right? So I would try to watch all the videos when I had time. It's hard. I mean, they're videos and you don't have that much time, but like, yeah, it just really helps because yeah, again, like Connor said, if you don't have that content base, it's kind of hard to learn on the go as you do it. But yeah, that's it. That's all I really had. It was just putting Sketchy in.
Okay, the last thing, and I will go fast, I promise. I mean, someone put in I was typing out a response, but I don't think Anki is necessary for third year. That maybe that's a hot take for me too. I am a firm believer that Anki might be necessary for first and second year. Now we can debate that on another day. I have used it every day of third year. I'm 50-50 on it. I don't think it's the biggest help during third year. That being said, before this webinar, I was doing my Anki for step 2. So I'm kind of talking out of both sides of my mouth here. But if you don't have the time, that's probably the resource that I would cut out in third year. Okay, last thing, patient presentations. These are the two most basic things. And when I say basic, I mean just raw expectations that you should know kind of what you're doing, and then you will know a little bit better by the end of the rotation. Just like Nick said, really every rotation is teaching you how to take a specific H&P for that population. That's really what you should take away from it. So a full H&P is, you got a new overnight admission, maybe none of the residents have seen them yet, you're the first person. So what's their past medical history? What's their surgical history? What's their social history? Do they use tobacco? Blah, blah, blah. What medications are they on? Likely someone has done that, but maybe if it's the afternoon, you're on internal medicine, that is your bread and butter. Where they say, hey, Connor, go down the emergency department, take an H&P on this new patient. That's a perfect med student task to do. And guess what? There's likely a template for it. So you don't have to memorize everything, but just know the basics, essentially. And then SOAP stands for Subjective, Objective, Assessment, and Plan. This is, now if you're not presenting a brand new patient, this is either the note or the presentation style that is kind of just bread and butter. So subjective is what happened overnight or what has happened so far. Objective is vitals, labs, imaging, and then you get to the nitty gritty, assessment and plan. What are we doing? I don't need to take a full H&P every single day I see a patient if they've been on the ward for 2 weeks now. I can just give you the pertinent updates and how they're doing. Maybe they spiked a fever overnight. And in my subjective, I would say febrile to 101.6. That's maybe all I would write in my subjective. Now I know that's kind of objective too. Don't crucify me for that. But still, they spike a fever. I put it in my subjective. That's just how I am as a person. Now the next slide gives you a little bit more insight. Is every clerkship is different. Every hospital is different. They likely have templates, but I am going to, again, plug Sketchy. There's 4 guides that are already out there and a couple more on the way. Each one of these guides has kind of the basics of what you need to know about what to ask and what to say during a presentation on each rotation. So while you might have a specific template for that rotation, want to let you know Sketchy's got you covered too. We might not have cool dot phrases yet. Hopefully, maybe that's a thing, but you can at least have some questions. I can say I wrote the psychiatry guide. Those questions in there are the same questions I asked every one of my psych patients for 6 weeks. And those are things that I'm not going to get from a template, but I'm going to get them from my residents telling me, this is what you ask a psych patient. This is what you do. So those are all in there. But I just also want to note, there's going to be a mix of everything. Every resident, every attending is going to expect something different from you. So always be prepared to adapt on the fly. You get better at it as the year goes on. Usually that just means they want you to either stop talking or cut things out. So if you have a really cool attending, maybe it's the end of 2 weeks working with them. Do I tell them that pupils are equal, round, and reactive? They're normocephalic, atraumatic. Their lungs are regular, lungs regular rate and rhythm. Their heart is regular rate and rhythm. Anything like that? No, I probably don't. I will likely say exam unchanged. That's something I feel you can earn after they've watched you for 2 weeks. You know what you're talking about. Then you can kind of cut some of those corners, which helps save time. Don't cut corners in med school. That's generally a bad idea. But if you can, then you can on this kind of instance. And again, always just ask your residents on day 1 what the attending likes. Some attendings like things a certain way. And so it's always good to ask your residents if they've worked with the attending before so they know what and they can tell you. And most of the times your residents are just going to do that anyway without you asking. They like to make you look good because that means they look good, which is generally just a win-win. It helps everyone out. Makes the attending's life easier too. I'm sure they know that we do it. So yeah, the free clerkship guides from Sketchy, I think, are something that doesn't really exist. My school has clerkship guides, but they're kind of thrown together, at the end of MS3. But I really think these guides are some of the best out there, and they're free. What could be better?
Yeah, so I think Jen just put some links in the chat, but here are, do people even use what are QR codes? Anyway, here's some QR codes for you to scan with your phone, I guess. The links are in the chat, which might be more helpful. These are essentially what you've just heard but more specific to each particular rotation. As Connor said, he wrote the psych one. It's great. Nick, I know, is working on a couple of others. So these I think are super helpful for more specific advice. You know, obviously we don't get down to the level of at your institute, like watch out for Dr. So-and-so, they're a nightmare, but like, because we can't do that, but it's nice to have a little bit more specificity. What are the questions you always ask for psych, things like that. So go ahead and grab those. We have 60 seconds for questions. But no, so I'll stick around at least for a bit. Feel free to ask any questions. I know people have been asking in the chat and the Q&A, and we've been trying to throw some answers in there. And while you put your questions in, we have a giveaway.
Nice. So what we like to do is we like to use Google's random number generator and grab a number, and whatever that number, that row is on that CSV for the poll, you'll be the winner. So I am behind the scenes generating. There's 160 of you guys, and the number that's rolled is 116. So let's see who that is. So the winner is Faith Keen from Drexel. Are you with us till the end? If you are, give us a shout in the chat. Faith. Nice. Congratulations, Faith. I have your email, so I'll be in contact with you for your free Sketchy subscription. Congrats.
Couple other questions. Will we need a new subscription for the upcoming new platform? Nope. If you have an existing subscription, it'll update automatically. Someone in the chat said and asked just hosts and panelists, I told you we were going to make fun of you. No, I'm just kidding. How can we get involved with the Sketchy team as medical students? Actually curious, Connor and Nick, how did y'all get roped into this?
I think I was fairly unique-ish. Sketchy was created at my institution by students at my institution, which is pretty cool. So I am one of the students at the school who helps run all the discounts. So this could be UWorld, Pathoma, whatever it may be. I help run them for all 4 years of students. Reached out to Sketchy and was like, hey, like, I would love to work together and, you know, simply just ask for a discount, honestly. And it kind of just morphed into this awesome relationship where I've now been able to help on some of the projects, really just tried to offer myself as an ambassador because I do love the product, and it kind of just morphed from there. I got really lucky. Everyone at the Sketchy team is awesome. So I would just say whenever, if like a recruitment goes out or something like that, you know, make sure you get that email, make sure you respond and are willing to like be a Sketchy ambassador. That's number one. And then do a good job, kind of show interest, just like you would in third year, and things can kind of go up from there.
Yeah, I think I just really liked Sketchy, and then there was the ambassador thing. I was like, oh, that'd be pretty cool, because I'm not really someone who's like really big on social media, or I'm a little too old for it, I think. But I was like, hey, like it's a cool product, and I really like it, and I actually think it's valuable. So I didn't feel super lame about talking to it and plugging it, because I thought it was, you know, it was cool. Yeah, I don't know, just really helped me. So I was like, you know, I think it can be helpful to other people. So super fun to be able to kind of like see behind the scenes, see how it was created. And yeah. Sorry, I'm tired. It's been a long day.
You've had quite a day. All right, last question, because someone who's taking step 1 and step 2 during third year, besides, you know, Craig, any advice for that person?
I know some kids that are doing this, or they just took step 1. Now they got to take step 2. I mean, it's just hard. It like, they they basically had to keep up with step one content during step two. With like the advantage is like you take step one, you get to forget about a lot of stuff until maybe step two comes. But like you don't have to remember all that biochem, less genetics. So it's just hard. It just means that you have to keep up on it. So I think just like give yourself bite-sized pieces. This is what it seemed like they were doing. It's like study a little bit at a time, just keep up with it, and then whether you take one or the other, which one first? I know I think it's different for depends on you, but I know most people took step one first. So you just kind of got to keep up with it, and then you got to turn your attention to step two. But you've been studying for step two during rotations as well, so it's not the end of the world. You could do it. You could still crush both of them. And I mean, step one's passed. Don't discount it, but and you'll crush step two. You can do it. It's just extra work.
Yeah, I don't really have anything else to add other than my school doesn't do it that way, but it's certainly something that I've heard from a lot of other people. There really is a lot of step one on step two. Now that I'm 6 days away from taking step two, there is a lot of step one on those practice tests. Now, is it going to ask me parts of the Krebs cycle? No, thank God it's not going to. But I still get random questions about enzymes every once in a while. So it might not be the best to do them back to back, but that's the situation you're in. Many medical students do it. And I actually think they can be beneficial. Like Nick said, I think they go hand in hand, and you will study for step one, it's pass fail, you get that pass, and then you focus on step two, where you honestly might be fresher on step two because of your recent taking of step one. You have better stamina, a lot of different things. So I actually think there are some pros to doing them back to back.
All right. Okay, I think we answered every single question. Thanks to everyone for showing up tonight. Thank you, Nick and Connor. This has been awesome, incredible advice, and a nice way to share all this wisdom that you've garnered over the past 3+ years. Keep your eyes out for that new on June 20th. And yeah, thanks for being Sketchy fans. And congrats to Faith for your good fortune.
You had a chance to say good faith there, and you chose not to.
There's only so many dad jokes I can make in a day. You know?
You work at Sketchy. It's allowed.
I do. The number is high, I grant you.
You work at Sketchy and you have kids. You are allowed to.
Ryan said it's crazy to see the face of the voice. My mom always said I had a face made for radio, so.
It was a real whirlwind when I met the Sketchy team for the first time. It was like, hey, it sounds weird, but like, hey, I've heard your voice so many times.
Yeah.
But
you
never really. Yeah, you're like, I have to watch a number of you every day to get through my life, and now you're a physical human being in front of me. Weird experience.
I think like Ricky's voice is like burned into my head from all the step one content, all the preclinical stuff, all the jokes too.
I will tell her that. She'll be honestly very pleased to hear that. Somebody has their hand raised. I don't know. What does that mean? Avnash, you got a question? No? Cool. Nick, is it 9:10 p.m. for you?
Yeah, 9:08, yeah.
Get out of here, man. What are you doing? Get out of here.
Believe it or not, I have to study.
Go study and then go to sleep.
Thanks, guys.
Yeah.
Thanks for letting me rant at you. It's my favorite thing. Bye, guys.
But it's only 6 for Con. you should go to.
Thank you all.
All right, everybody. Thanks so much.
Thanks for joining us. Bye.